Welcome to Louisville Lectures, PEM Little Lectures.
Hi everyone. Today we're going to go over the approach to the Fussy Infant and learn a mnemonic to help you remember the differential. So you're working in a busy ED and a mom comes in with her 2-month-old and the chief complaint is fussiness. So as you prepare to go into the room, it's helpful to keep in mind the differential for the fussy infant. And this can be remembered by the mnemonic, it cries. I love mnemonics, and this is a great one because it describes exactly what the baby's doing. It cries. So let's begin. The first I is for infection. So things you want to keep in mind are urinary tract infection, especially in these young infants. Fussiness may be the only sign. They also may have fever. Meningitis or sepsis is always high on our differential with the infants, so look for things like fever, decreased energy levels, and not waking for feeds. Now, babies who have meningitis can have what we call paradoxical irritability, where they're super fussy when they're being held, but calm when they're being set down, which is opposite of what we usually think about with infants. And this is because they're being kind of smushed when they're being held. So if a baby would rather lie on the exam table and not be held, think meningitis. And in babies, also look for that bulging fontanelle. Other things are candidiasis, either thrush of the mouth or diaper candidiasis can make you pretty fussy. And while you're looking in that diaper area, be sure to check for pararectal streptococcus, which is a beefy red rash and super painful. The T is for trauma. So things we think about in babies are non-accidental trauma, subdural hematomas, and fractures. So look for a history of a baby falling or being dropped. And especially in patients that are less than 4 to 6 months who roll off a couch or reportedly rolled off a couch, always have a kind of high suspicion for non-accidental trauma. I like to approach these by asking the family, oh, did they roll? How long have they been rolling? And get a little more history. Also, when asking about being dropped, I do, things happen. So try to be nonchalant and say, so did the baby fall or get dropped? Because we're not here to judge. We're here to find out what's going on. You want to palpate all of those extremities, and if there's any pain on palpation or if they're moving one of the extremities and seem to have pain, you want to check for any fractures, as well as look for bruising. And remember that kids that don't cruise rarely bruise. So bruising on these little infants would be concerning for a non-accidental trauma. The C is for cardiac, and this can be our congenital heart babies, but these typically come in with a history of congenital heart issues, so it's higher on your differential. Something that may be a little more subtle is supraventricular tachycardia, and these may only present with a history of fussiness or not eating. Now, in the infants, the heart rate is consistently greater than 220. And what I mean by consistent is regardless, while you're in the room the whole time, it is just tacking away, not it jumps and then mom gives them a pacifier and it goes back down. That's not as consistent with SVT. And while we're talking about SVT, if it's an adolescent or adult, you want to look for a heart rate consistently greater than 180. When you get an EKG, it's going to look similar to this, where your P waves are hidden in the QRS. And just briefly, the treatment of SVT, you'll want to start with ice to the face or Valsalva if they're older. And if that doesn't work, adenosine. And remember that the first dose is 0.1 mg per kg with a max of 6, and your second dose is 0.2 mg per kg with a max of 12. R is for reaction to meds, reflux, or rectal or anal fissure. So when asking about medications, you want to ask about what the patient's taking. Also ask about any supplements, because sometimes families don't think about these as medications. And if mom is breastfeeding, ask if mom is taking any medications, because whatever she takes in can be given to the baby and they may have a reaction to that. Reflux is those small volumes of spitting up that are so common in these little babies. Now remember that it can be normal, but if it is painful or if the baby is losing a lot of weight, there is concern for GERD and they may need a little more exploration. Now fissures can be caused by forcible Valsalva maneuver as seen in constipation. Now those by forcible Valsalva are typically at the 12 o'clock and 6 o'clock position. So remember, benign occurs at midline. Whereas if there's a fissure off of midline, think of a tear because something is being inserted into the child. And these are typically at the 4 o'clock or 8 o'clock position. Now, when I say something being inserted in the child, I know our first thought is going to abuse, and yes, that's always on the differential, but it can also be from a baby who's getting way too many enemas or they're getting really frequent temperature checks. So ask if the family's doing any like rectal stimulation or enemas to help with, say, a constipation that they're coming in with. I is for intussusception. So our classic triad for intussusception is colicky abdominal pain, but do remember that the patient may be lethargic if they're coming in late. The sausage-shaped abdominal mass and that current jelly stool, which again is a really late finding. And this is caused by the kind of telescoping of the bowel, one section into the other. And the peak incidence is between 6 and 9 months. You're going to diagnose this on ultrasound. You're going to see the target sign on your transverse as well as see some telescoping bowel on your longitudinal. Next is eyes. You can have corneal abrasions or foreign body. So you'll want to do some fluorescein stain. And the most common cause of corneal abrasion in these babies is actually them scratching their eyes with those little razor sharp nails. But you also, when doing your fluorescein stain, want to evert the eyelid to look for any foreign body that may be trapped under there, especially if there are vertical uptake of dye on your fluorescein. Glaucoma is rare but should also be kept in the differential. Now, 40% of these are present at birth, but 85% are diagnosed by the first year of life. And the common presentations are excessive tearing, photophobia, blepharospasm, which is a fancy word for eyelid twitching, corneal clouding, and conjunctival injection. S is for strangulation or surgical process. So you want to look for things like hernia, testicular or ovarian torsion, or hair tourniquet. So hernia and testicular torsion, you typically see scrotal swelling and scrotal pain, so they're pretty easy to pick up. Ovarian torsion is a little harder to pick up. Luckily, it's rarer in these patients, but if a baby seems to have a lot of abdominal pain and your abdominal workup has been completely negative, something to consider. And then a hair tourniquet. And these can be on any of the digits, but you can also see them on the penis or the earlobe, so make sure to get a very good look at all the extremities or anything that a little piece of hair can be wrapped around. So there's our mnemonic. It cries, but now you won't. I for infection, T for trauma, C for cardiac, R for reaction to meds, reflux, rectal anal fissure, I for intussusception, E for eyes, S for strangulation or surgical process. Thanks for listening.